and then we will discuss them. We will stick with a relatively strict timeline, and so that we have enough time for discussion. We might want to wait another minute or so because we're still a little early. And how do I tell how many people are on here? I don't see that here. Participants, 33. I see that. Okay.
It's 33 and counting up. So people are just getting connected.
Yeah.
We still have a couple of minutes more.
Hi, good to see you, Doug, Ed,
Thanks, Solomon.
Nikolay, Sandeep. How are you?
Good.
Very good. Well, then I'm going to start
How are
over.
you?
Not bad, Mehmet. Where are you hiding?
I'm
You
here.
don't want to know.
Vesel, it's good to see you. I don't know. There he is.
Yeah.
Hi.
Okay, we'll start all over. I'm Ed Benzel from the United States. This is welcome to the first spine board for the World Spinal Column Society. We have 4 panelists who will individually present each of 4 cases. Doug Orr from the United States, Nikolay Peeve from the UK, Selman Sharif from Pakistan, and Mehmet Zalali from Turkey. Dr. Orr, are you ready for the first case?
Okay, let me just share.
While he's doing that, we need to all stick to a tight schedule because we have 4 cases to present and we want to make sure they all get their fair share.
All right, can you see my screen?
Yes.
All right, so this is a case presented or that's been put forward by Denis Ivliev in Smolensk. It's a case for hangman's fracture. So the history, the patient is a 43-year-old male. He was involved in a road traffic accident about 2 weeks prior to this. He's complaining of neck pain, VAS in the 7 to 8 range. Difficulty moving his neck, probably due to pain. No neurologic findings. And here is CT scans showing fracture of the pars of C2 with a little bit of slip forward. You can see my cursor here. A little bit of slip forward of 2 on 3. And his questions are, how is this best managed? The advantages of going anteriorly, posteriorly, what are the options? So just as a little beginning on odontoid fractures, they're classified in a scale of 1 through 4, with 1 being an undisplaced fracture, 2 being a displaced fracture but no loss of alignment at C2-3, 3 being angulation C2-3 but an intact anterior longitudinal ligament, and 4 being translation with a non-intact anterior longitudinal ligament. So panelists, your thoughts?
Selman, how would you deal with this case?
Ed, I'd like to see actually more pictures. I need to make sure that this is nothing but type 2, so you would need more images for that. So
What
I'd
images,
like to see,
what images would you like?
Clearly, I'd like to see axial because really on the 3D reconstruction, I can't make out what's happening.
Yeah, unfortunately, we don't have axials, but let's just assume that this is a not very complicated. It's bilateral pars fracture, no comminution.
Okay, and patient's neurology. Sorry, you told us there's no neurology. Okay, I think in this particular case, obviously, you can do a couple of things. Obviously, I would think about fusing this along with bone graft. And it's very simple to put in either pars screws, or you can think about if possible, then you just do C1, C2 fusion.
C1, C2?
Sorry, C2, C3 fusion. I do apologize.
Okay. Would you do anteriorly, posteriorly?
I think it's much simpler doing it posteriorly.
Nikolai, what are your thoughts?
Yeah, I agree with Salman. Alternative to posterior is anterior, C2, C3, cage and plate. You can consider that as well. You can do just C2 screw, par screw. You try to reduce it if it's simple and if it's possible. Obviously, if that's not possible, then you have to consider a longer construct, as someone said.
Mehmet?
Yeah, this is type 2 because there is a very mild subluxation. I would rather do a conservative measure treatment. I wouldn't operate it, the patient immediately. I
What would
would
be
place him in a rigid collar and observe with the direct X-rays. If there is a increase in dislocation, I can consider doing a posterior fixation.
This is one where, and I usually don't get MRIs in most traumas. I think in most traumas, you get everything you need from the CT. This is one where I actually probably would get an MRI. And the reason is I want to take a look at that disc. If I don't think that disc is particularly disrupted, that this is a true type 2, then I would seriously consider just doing a primary osteosynthesis here. You could even be done with just percutaneously. You take a 4.5 partly threaded screw with a washer, and you cross the fracture site, and then you use a lag technique to close down the gap and treat it without a fusion.
There is an interesting question from Stacy Darwish. She's asking if anybody would do 360 fusion here.
No, never.
It's
Because it's indicated in case of type 3 fractures only.
There's another question, C2, C3, ACDF. I mentioned that I would consider.
Would anybody consider non-operative management? Say,
Yeah, that's
in
what
a
Mehmet
halo?
said.
Yes, I am for non-operative management.
Because this is the way we would have treated this years ago, with true neck extension and capital flexion in a halo, which reverses the deformity, creating force vectors. And these heal very
Exactly.
well.
Yeah, exactly.
I agree. Ed, sorry, that's a good option, but the problem with Halo has been that very few people will be able to really manage them, and lots of them have a lot of painful issues and problems with Halo. Significant side effects associated with it.
Keep in mind that I'm speaking of 20 to 30 years ago, when we didn't think like we think now about leg screws, et cetera, and dealing with a fracture like this. And I would venture to say that when I was a resident and young faculty, that the vast majority of hangman's fractures were treated non-operatively. Now it's different. I think it's because our surgical options are so much better and more well refined.
So Ed, probably if you are Doug Orr and practicing in Cleveland, and if you have the fancy like screws and navigation, then probably this is a good option. But if you are trapped somewhere in Africa, for example, and you don't have these resources, probably conservative management would be still a good option. What do you think?
I would agree with that.
Completely. The one thing that I would say, this guy is young enough in his 40s But if he were older, say in his 70s, I would be very reluctant to do an anterior because of the dysphagia issues with operating anteriorly this high up in the spine.
Dr. Orr, be careful how you define old.
I remember the course this year. I told you how I defined old. 1 year older than Ed's current age.
So the surgeon on this case, can we unmute him and see what he did or planning on doing?
Imad, can we unmute?
Unmute yourself.
Dennis
Yeah.
Ivilev.
Yes. Sure, sir.
There he is.
Hello, dear
Dennis, glad to meet
colleagues.
you.
Nice to meet you all. Could you please repeat your question? Unfortunately, I didn't catch what have you said.
Just wanted to know your thoughts, your thought processes, and what you decided to do, or you're deciding you're going to do.
I did this surgery. I performed this type of surgery because, in my opinion, I have to use screws, posterior screw fixation, and reduce this gap, bone gap, and create conditions for healing, for fracture healing, due to screw fixation.
How did you reduce this?
Three-hand technique without any navigation.
No, but the reduction maneuver. What did you do to get the fracture fragments apart?
Using special screws with partial screw.
So you used a lag technique.
Lag technique, yes.
Okay.
Probably
we
yes.
have
What
any
did how did you
postoperative
position?
images?
What did you use? Mayfield or Gardner
No.
Wells tongs, or how did you position the head?
No, without any Mayfield device. Just light patient without any devices. Just performed a special channel with screws in C2.
Do we
Let's-
have images of the postoperative?
Yeah, yes, I have post-operative images, follow up approximately 4 months, and let me show you if you wish post-operative images.
We have 2 minutes here. So
Okay.
quickly. You don't have them, right, Doug?
No, we don't with the when we modified the file.
Doug, maybe you could unshare so you could share, please.
Oh, yeah, sure.
Thanks.
How do I stop sharing?
I did it, sir.
Okay, he's done it. All right. Okay, Dennis, can you share your screen if you have the picture?
I'll
Okay.
try my best to do it. Let me try to do it.
Okay,
Do you see?
Yes, very nice.
that's nice reduction.
Nice
You-
reduction, yes. Let me show you.
And is that a trans-pars screw? So you get the pars screw fixation plus C3 fixation to C2.
Because I hold in mind the disk C2, C3 disrupted. I thought that C2, C3 disk was disrupted. This is why I used 4 screws.
Yeah, that was the point I was making, that this is one of the few cases I would have ordered an MRI because I would have liked to have seen how the disc looked. And if the disc was disrupted, I would have done exactly what you did. If the disc wasn't disrupted, which does happen, I like the idea of just doing a primary osteosynthesis.
Post-operative images
Yeah, very nice.
for FAMA posterior screw fixation, solid bone fusion.
Very nice. Thank you. Okay, Ed.
And it's a very nice job and a great first case for our first meeting.
Thank you. Thank you so much.
You bet. Our second case is
Oh, if you could
presented by
unshare.
Nicola Peeve from UK. Okay. Wait, Nikolai, we can't hear you.
Sorry, I was muted. So I'm gonna share now. Okay. Oh, see that? Yes.
Yes.
But that's the end. Can we go to the beginning?
Yeah, sure. I think that's a good idea. Okay. Right. Okay. So I'm going to present to you today a case from Stanislav Adamski from Copernicus Hospital in Gdańsk in Poland. He is presenting to us a 20-year-old male who had a fall from a height from a scaffolding of 2 meters, and then he sustained trauma, and as a result of this, back and so he was complaining of interscapular pain that worsened with changing the body position. He was conscious and he was GCS 15 from what I see here. No neurological deficit, no deterioration with time. He is a young, healthy individual. So they performed imaging, CT scan and MRI scan, and that is what we see. So the questions that Stanislav is asking is, how would you classify this fracture, and what would be your surgical or any surgical or non-surgical solution for this? I have the post-operative images, as you have seen it. You had a glimpse, but we'll discuss them later. So maybe I can start with the panelists. So Dirk, what would you do?
Well, first off, defining the injury. This is not a pure anterior column injury. You can see, I don't know which level is which here. Oh, sorry, 6 and 7. There's a facet through the inferior articular process of 6, or there's a fracture through the inferior articular process of 6. And then there's also a fracture that looks like it probably goes through the pedicle at 7.
Yeah.
So this is more along the lines of a posterior failure, flexion-based failure. If you want to go with the AO classification, this would be a B type. So this is one, the high thoracics, even in a B type, they don't tend to move a lot. The problem is it's really hard to brace these if you wanted to do something non-operative. I think his overall, it would be, he's a little bit kyphotic, but probably an acceptable degree of kyphosis. I think I would consider in this, I think this would be a good indication for doing an all posterior pedicle screw based construct. I would probably span 4 through 9. And I would instrument the affected levels.
Okay, all right. So what about the rest? Salman, what would you do?
Sorry, I missed the history. I was just doing something. I apologize. But
He had a fall.
Fall 2 meters, landing on his back and shoulder, upper back and shoulders, neurologically intact.
I think you could do it both ways, but what if it's causing a little bit of kyphosis and you've got these fractures going through? I think it's worthwhile maybe just doing pedicle screws, MIS. That would be the way to go. And yeah, I agree with Doug to go a couple of levels above. So I think that's what I would do as well.
Okay, Ed, what is your opinion?
Well, first of all, let's hear from Mehmet.
Okay, Mehmet.
There are three vertebral bodies who have been affected by the trauma. The most is on the C7 level. 6, 5, and 4 has also some so-called stable compressions. Probably we can consider C7 as an unstable. The height loss is too much. But I think even if it is in the upper thoracic levels, I can still consider a conservative treatment for this. How old was the patient?
20.
20.
20. Yeah. I'm not sure if our aim is to correct the kyphosis. There is a mild kyphosis at those levels. If we try to correct it, and the fixation levels must be too long, must involve also T4 and go down to T7. This is a
Right, T7.
major
is the
surgery.
apex.
Yeah, major surgery. Yeah, we can discuss it with the patient. There is a risk of increasing of kyphosis, but we don't know it. No, we are not sure for that.
Okay, so shall we hear Ed before I present the outcome?
I would seriously consider non-operative management. I would have a long and hard discussion with the patient. It's going to be difficult to correct a deformity here from a dorsal approach. An anterior approach seems excessive, and he's young. He's probably going to heal this. And finally, the morbidity of a long segment fusion in a young person cannot be should not be minimized over time. If I were to operate, I'd do what Dr. Orr said, but I would talk to the patient about non-operative management.
Well, what I would do here actually is I would do percutaneous instrumentation with a view down the line of actually taking it out.
Okay.
So no,
Well,
I would not fuse him. I would just instrument him until he got bony healing.
Okay.
I think Ed, I'd change my mind. Actually, I'd go with conservative treatment if patient is 20.
Even with the posterior tension band failure?
Yeah, but I think, he's going to heal. Most likely he's going to heal. He's only 20, unless he's got some other problems.
Do we have posterior and also anterior ligament failure?
Well, I mean, there is a failure, with the fracture, those are tension band failure fractures at both 6 and 7.
Yes.
And
So I
can
would be
see,
concerned about the posterior elements.
you can see on the right-sided MRI T2 weighted image, I think.
It's a stir, actually, yeah.
Yeah, you can see some ligamentous injury, soft tissue injury dorsally.
You can suspect maybe even anterior ligament injury.
Wouldn't be anterior because there wasn't it wouldn't fail anteriorly, wouldn't fail in compression.
You're right. Yeah, you're right. Okay, right. Okay, so I would agree probably with a young person, minimal invasive PERC screws, and I would agree with removal as well. And because he's 20, I would be a bit, conservative is okay, obviously as per the patient's desire, but because he's young, he wants to mobilize soon, maybe consideration of PERC screws and removal would be my option as well. So this is what Stanislav is asking, how to classify, how to treat, when to follow up. So this is his solution. I can see that he has elected to go percutaneous. He has done that's 7, 5, and 7, 6, and 5, so above, and then 8 and 9 below. he has elected to do, I think this is a form of kyphoplasty, but I'm not sure what exactly is that. So maybe we can ask Stanislav to explain to us what exactly is that technique that he has used. Imad, do you want to unmute Stanislav? And so
Sir,
maybe
he
he
is
can.
not here.
All right, okay. So I can see that he has used a form of kyphoplasty to do
Yes,
the reduction.
it's umbrella kyphoplasty.
Okay, I don't use that, so I don't know what is this. But seems like he has managed to do some reduction there, and he has done above and below, 2 level above and below.
Is that methyl methacrylate in there?
Sorry.
Is that methyl
Yes.
methacrylate in there? Cement.
Yes.
Yes,
Yes.
you inject cement at the end, yeah.
Ooh. I'm not a big fan of cement in 20-year-olds. There's an osteolysis that's associated with cement, and you can get late failures because of that. Cement is great in elderly patients, but I am not a fan of cement in young people. There have been a couple comments on the chat about the neurologic status. This person's completely neurologically intact.
Yes, correct. Yeah, that's what he was announced. Yes. Okay. Well, if Stanislav is not here, then we heard different options. Again, conservative option was prevalent among all the panel. I think that this is of course a valid option, but if you want to be proactive, depending on patient's choice, probably you can consider minimal invasive techniques. We heard about the negative comment about the cement in young people. I think we can carry on further.
Just a couple of comments. In terms of the other thing you got to always consider, and if you're 20, there are 20-year-old males, and then there are 20-year-old males. In the decision to elect, one of the advantages, if you will, of operative treatment is if you don't think this is likely to be a very compliant person, trying to treat non-operatively somebody who's going to be non-compliant is a nightmare, and you actually have to invest a lot more work in the non-operative treatment of a patient like this with repeated visits, repeat x-rays. And if you don't think this guy's going to follow up, you may actually be one. So here in Cleveland, Tim Moore, who works at our county hospital, he rarely in young males, because as he says, I'm going to see them once. I'm going to see them in the OR, and then I'm never going to see them again. So that's something to consider as well. Find out, what type of 20-year-old you're dealing with here.
So there, just as an aside, Dr. Darwish and others have expressed concern about methyl methacrylate in a young person, as Dr. Orr did, and I would echo that as well.
Besides, if we are presenting such cases, we must also bring the postoperative films, not only the intraoperative ones, even the long follow-ups we need to see.
Do we have follow-up images?
Unfortunately, this is all. This is all that I have.
Okay, but that one there at least helps us a little. Okay, see that the problem, as I see it, is you get young, healthy bone, albeit it's collapsed, but you're separating bony edges with a non-biologic substance, methyl methacrylate. Which,
and if you ever have looked at the histology of a cemented vertebra, there is cement. You see the main blob, but there is cement infiltrating that entire vertebral body. So it's no longer a biologically active bone. And that's why I think we use cement with extreme caution in young people.
okay. Nikolai, if you could unchair, Dr. Sharif from Pakistan will present the next case.
Sure. I think somebody unshared me already.
Okay.
So this case is from Tareen Shahzadi. She's from Sir Gangaram Hospital, and I think that's in Lahore, if I'm right. 35-year-old married male, right-handed driver, presented in OPD with complaint of lower back pain for 1 month. Pain was gradual onset, progressive, non-radiating, associated with difficulty in walking, aggravated on standing, walking, prolonged sitting, lying down and straining, and relieved slightly by taking painkillers. Ability to walk deteriorated progressively from difficulty in walking to unable to walk with support, and later chair-bound. Developed urinary and fecal incontinence, no history of low-grade fever, anorexia, weight loss, appetite, or sleep disturbance. Rest unremarkable. Examination, young men, normal height, conscious, GCS 15, cranial nerve cerebral examination normal. If you see in lower limb, the tone was reduced, SLR was 60, power was 3/5, reflexive or equivocal, and planters were downgoing. So this was the scan that was shared. And if we see further axial, so this shows again something happening. And then obviously the question was that this, what nature of surgery would do. This was Ewing sarcoma biopsy proven patient, and what outcome would we have? So I think let's start with Doug.
Wow, this is bad. You know, you have extensive, I've never actually seen purely epidural Ewings. That's
Well,
kind
it's
of a
very,
surprise.
very rare. There are case
Yeah.
reports. It's very, very rare and bad outcome anyway.
Yeah, but you know, right off the bat, you know, if we go back to the principles of managing Ewings, the principle of managing Ewings, if you can't get an en bloc clean margin resection, they're going to die of this disease. And so first off, the prognosis here is terrible, no matter what we do. And again, going back to principles, neoadjuvant chemo and radiation is standard for Ewings. And what you're doing it for, is it has shown to, in a potentially resectable lesion, which this is not, it has been shown to improve outcome. But the other thing is, the reason we do it is that you do your resection based on what's left. So often in terms of, you know, the more classic places for Ewings, like distal femur, you can often do it with the neoadjuvant chemotherapy. You can actually shrink things enough that you can limb salvage. Obviously, that's not an option here. I mean, I think here it's neoadjuvant chemo and rads. Hope it debulks the tumor. I don't know whether it makes any sense to go in operatively or not. I would be, you know, you would buy a little bit of time of neurologic status, but you're not going to change outcome here.
Dr. Alkani wishes that we go back to the MRI, which you just did. Great.
Mehmet, you want to go next, please?
First of all, can I ask Dr. Orr, how do we know this is epidural?
I'm just assuming. I'm assuming it is. There is an intradural form, though it tends to occur more cerebrally. It's often, well, it's interesting. The same tumor is called a PNET, primitive neuroectodermal tumor, if it occurs in the brain, and it's called Ewing's if it occurs in the appendicular skeleton.
Can I comment on this?
Please.
Yes, please.
Actually, the biopsy is probably taken from somewhere else because it is biopsy proven. It means that there is another source of the Ewing sarcoma. This is, I'm sure this is intradural. I've seen a few intradural Ewing sarcomas.
Mhm.
It is possible. And the surgery will not give any benefit to the patient because it will be a very adherent tumor to the cauda equina parts, and you will not be able to remove it. You can make a surgery, but you must tell the patient that it will possibly not give any benefit to the weakness and to the outcome of the patient. Because you cannot make, as Doc has said, you cannot make a limb salvage surgery or like a total spondylectomy. It is impossible for this case. So I would rather do a adjuvant chemotherapy and not touch this tumor.
That would be my plan.
If you look
Nicolai?
at the, if
Yeah.
you look at the sagittal MRI at L12, I believe, it sure looks like it's intramedullary, infradural, as we see the spinal cord, or spinal fluid.
Yes, it is intradural. Yeah, for sure.
Right.
Yeah, Nicolai?
Yeah, I agree with the consensus opinion. It's indeed a tragic, very, very bad case for the patient. As soon as the tumor is confirmed to histologically, I think at that point the surgical options are exhausted. I don't think there is point to operate the patient because that's not going to help much, but only will keep the patient in the hospital unnecessary and will expose the patient to chance of complications. So there is no point for that. So adjuvant treatment is what we can do, but unfortunately, as we know, that's also not going to give significant improvement. So poor prognosis case, unfortunately.
So of note from the chat area, this is intradural with no Mets at this point.
Okay. Maybe we can get Tehreem Shahzadi to find out what these people did. Usually in our hospital, obviously we'll have a oncology board meeting in which we discuss this along with radiotherapists, the chemo-oncologist, and neurosurgeons together, and would come up with a plan along with pathologists. So, and that's how we go about it. So let's see what Tehreem did. Can we unmute Tehreem, please? Imad?
Yes, sir. I did.
And
Yes.
if he has slides, you need to unshare.
Okay. Tehreem, do you have any slides to present?
She's not there, I guess. She's not unmuting herself.
Tehreem, can you unmute yourself, please?
No, she's not doing it.
The general consensus is non-operative management. Once
sir, she's not-
diagnosis has been established.
Okay. I think she's not unmuting, maybe, I don't know.
So there's a suggestion by Dr. Darwish that we get a SPECT scan because it's very unlikely to be associated with this extensive disease in the lumbar spine not being associated with METs.
I'm not sure
Point
that,
well taken.
well, I'm gonna argue against it, just that what, other than knowing the extent of disease, it's not gonna alter treatment.
Okay. Depends on resources and many other things too, but you're absolutely correct. Okay. This puts us a little ahead of schedule. Our next and last patient is presented by Dr. Zaleli from Turkey.
Yes,
Can you
I'm
share
sharing
your
the
slides?
screen.
We see you. There we go.
And
We see
is
an
it
Andy
there?
because he's on the boat. We can say that.
Sorry. You can
I'm
see the
saying
screen?
that
We can see your screen.
Yeah,
we
okay.
see you and we see that you're on a boat and we envy you.
Ah, yeah. Thank you. Sorry for that. That actually,
You have to show us your
Um,
boat at the end.
yeah. This is a case from Dr. Carolina Santos Silva from Portugal. He is with Dr. Paula Pereira. And this is a 51 years old female patient, warehouse employee, modified ranking scale 1. And she has a medical history of epilepsy, papillary thyroid carcinoma, hypertension, and taking drugs about them. And in March 2020, she has had 1 level ACDA, this is artificial disc, so C45, and the other level ACDF fusion for a cervical myelopathy and left cervical brachial pain. And in July 2023, 3 years later, she developed bilateral cervical brachial pain and mild myelopathy. Joa score is about 16, and neurological examination have shown that global muscle strength 4 out of 5, Tromner sign and positive Romberg test, and these are the images we will see now. Sorry. This is a C45 level artificial disc, C5, C6 level occasion graft. You can see. These are the new films and flexion extension films. There is almost no movement. Probably the artificial disc level is also fused. And on MR images, there is a central compression at C6-7 level. Here you can see this is the axial image. And the presenters have done this question. My main goal with this case is an open discussion. The main questions would be who would propose surgical treatment to this patient? And what treatment would they propose specifically if they are operating? This is the MR, this is the CT scan.
So
Now we
Mehmet,
can come to the discussion.
the patient improved after the surgery and then deteriorated again?
Yes, exactly.
Okay.
3 years before first surgery. I don't know what was the reason that 1 level ACDF, 1 level artificial disc, but it was done this way. Let's start with the Salman.
Yeah, I think if the patient has persistent symptom and has had trial of conservative treatment, then obviously sorry, Mehmet, can you show the MRI? Somebody wants to see the MRI? If you could just go on the MRI, yeah. So if the conservative treatment trial fails, then obviously you could consider either doing arthroplasty at this level or consider fusion. I don't do arthroplasties as a routine, so I would go back in and I would choose this level. The important thing is to ensure that you keep it as minimum as possible. So you don't dissect much above and below. Already 2 levels are fused, so you don't want to be causing more problems with this patient. And I think generally speaking, can you go back on and have a look at CT as well? Sorry again, I apologize. Yeah.
Business.
Yeah, so this is not bad, but that those osteophytes need to be drilled, whatever we do, to ensure that they don't cause problems afterwards.
Would you touch also the other levels? Just C6, 7.
Just 6, 7, because if you see the MR, they don't show, despite showing these osteophytes here, they're not showing much pressure on the MR of the films that we have.
And you will make just HCDF?
Yep.
You will not place any plate, anything afterwards?
I usually use a plate every time I do ACDF.
Okay. What do you think, Nikolai?
Right, so yeah, I probably will do what Salman said. As you can see, the disc arthroplasty is subsided and it's fused. There is subsidence also at the lower level. But I would just probably go to the symptomatic level, which I believe is the level below. So it's adjacent segment degeneration and disease. I would address that. I do arthroplasty. However, in that case, that will not be my choice for obvious reasons. I would just do a simple ACDF. I would probably use one of these zero profile cages, which are fixed with screws as well. So that's alternative for me to a plating.
I'm going to disagree on the statement that this is fused, because if you look at the extension film, you can see a gap between the two end plates of the disc arthroplasty that you can't see on the flexion film. So this is still mobile. Years ago, they looked at the long-term follow early Bryan discs, and what they found was that beginning about 8 years. Everybody still there?
Yeah.
Yes.
Okay, so beginning about 8 to 10 years out, the patients who had their Bryan disc for myelopathy began to develop, about 30% of them developed recurrent myelopathy at the index level. And if you look back at the MRI, I'm sort of looking 10 years down the line here. You've still got a mobile arthroplasty. They're starting to develop some adjacent segment degeneration above the arthroplasty. They've got adjacent segment degeneration below. And I would be thinking here, actually, what I would probably do is I would probably do a laminoplasty. She does this, the history didn't mention that she had any neck pain, and even that is questionable whether. So I think I would just do a laminoplasty, preserve her motion, decompress her from the back. You could, for the arm pain, you could do foraminotomy at the 6-7 level as part of your arthroplasty or as part of your laminoplasty. And I think that's how I would go. I would go laminoplasty here.
So Dr. Orr, thank you. Because I was thinking this and thinking that I would be the only one and considered a criminal. But if there's two of us, we don't go to jail. So there's other reasons to support the notion of a laminoplasty. There is a little motion there, number one. Number two, the joint doesn't seem to move that much. And perhaps most importantly, it appears to have a low T1 slope or a low slope. In other words, the disc interspace is relatively horizontal to the floor in the standing position, which means it's a relatively stable joint, and doing a laminoplasty should not destabilize too much. There is a question in the chat, by the way, regarding if you do an anterior, do you go from the same side or the opposite side? So people comment on laminoplasty and on the side of approach.
That wouldn't stop me to go on the same side. Yeah, I know some people will be worried about possible scar tissue, but just one operation here, so that would not stop me to go on the same side.
I think the worry there is regarding problems, especially related to ENT. So I'd get the ENT guys to have a look down and make sure that everything is okay. And if there is no need of worrying. It's a very simple procedure. That doesn't take long. And you can get those osteophytes out at the same time easily.
There was a comment from the chat regarding laminoplasty and does she have enough lordosis for laminoplasty to be okay? And yeah, she does. If you draw a K line there, the K line is at the back of the vertebral bodies. So probably, you know, there's enough lordosis there that you wouldn't have to worry about it.
Yeah. Sorry, I was disconnected, but I think you discussed more details.
We've got half of the panel wanting to do an ACDF at the other level and half of the panel wanting to do laminoplasty.
Good. Can we get connected to the author, presenter? Dr. Carolina, is she with us?
Yes, she is.
Yeah.
Carolina, can you unmute, please? She's there, but she has to unmute herself. We've asked her
She
to.
is not unmuted. No, she's not responding, sir.
Okay.
So we don't know what they did.
But that was the idea of our doing these presentations, is to solve their problems if they have any, and if they can solve it themselves, then obviously we say, wow.
Right, but oftentimes they've done something and it'd be useful to gain knowledge from their experience, but well,
They haven't disclosed what they have done. They haven't.
So they comment from the chat, why not just do a C6-7 for amyotomy? Well, that would deal with the arm pain, but would not deal with the myelopathy.
yes, and the canal is very stenosed at that level on the axial view.
Yeah. I am also for an ACDF for this patient.
Well, Mehmet, you're not alone. That is the conventional thinking. And the reason I was glad that Dr. Orr remains unconventional is that as those of us who do laminoplasties do more of them, we see that you don't necessarily need to have a robust lordosis. You can even have a straightened spine and have good results with laminoplasty. Laminoplasty is associated with a fairly good outcome. And fusing another level has its drawbacks as well. I think either approach is fine.
Particularly, my reason for doing with the laminoplasty is the long-term is a couple of things. Currently, the symptomatic lesion is 6-7, but I'm looking at 3-4 on that MRI is starting to get a little bit narrow. And in the back of my mind, I've got the data on the Bryan discs that show late recurrence of myelopathy at the level of artificial discs. And so my thought of the laminoplasty is the ACDF is absolutely going to treat the current problem. My hope with the laminoplasty is not having to come back and do something at 3-4 or revising 4-5 if she develops myelopathy.
Is the reason for the stenosis the residual bone debris from the Bryant disc?
This was one that it was so early and nobody had been thinking about it that they didn't come up with a lot of reasons. I think some of it is with the Bryan disc, because it was a floating core, like the old Charité lumbar disc. I think there was a little bit of shear issues with it and probably causing some more degeneration of the facets.
Okay.
And then, you know, you're starting, you know, if the patient was myelopathic to begin with, you're already starting with a congenitally small canal.
Yes.
So I think it's just, again, I see so few patients that I consider candidates for artificial disc, that when I do get one, I'm referring them off to somebody who does a lot of them. But I would be reluctant to do artificial disc in myelopathy, but it doesn't sound like this patient had myelopathy to begin with, but does now.
Yeah. One of the things, the additional attributes of a laminoplasty is that it burns no bridges. You can still do a posterior fusion and a laminectomy if you need to. You can still do an ACDF infusion if you and plating if you need to. So it provides a sort of a hidden advantage for a select few patients.
I have a number that arthroplasty patients will develop ossification at the level 20% of the cases.
Yeah.
What do you think in the long term the real fusion of arthroplasty level?
I think the short answer is we don't know the answer to that. It seems as though the ones who do arthro-Ds early. And it doesn't seem like there's too many of them that have a mobile disc that 10 years down the line it fuses. It seems to be if they're going to fuse, they fuse in the first year.
Yeah. The so-called heterotopic ossification, I mean, 20%. But the long-term fusion level, fusion may be more.
Yeah, probably.
Yeah.
Well, we are still a bit early, but I think it's we've had a very successful first World Spinal Column Society spine board. I am extremely impressed with the cases and with the presentations and with the discussions. This gives us quite a bit of fuel to move forward with this in months and years to come.
Good.
So Ed, Stacy is asking, would you prefer cases in future with solutions or pre-op?
In the future, I think
Yep.
the solutions, what the physician did is good, but to save it until we present the case and discuss what we would do, and then we can see what the original presenter did.
I think though there's also one of the ideas of this forum was that it was also for people who haven't decided yet what to do.
Yes, and that's fine too.
And so I think we don't want to discourage those, because if if the idea of this is to help people decide what to do, I think that we should encourage that as well.
Yes.
There's another question regarding endoscopy for C6-7 foraminotomy.
Again, it would only deal with half the problem. It's the patient has radiculopathy, and certainly that would deal with the radiculopathy. But I don't think a foraminotomy is going to deal with the myelopathy, which is the more concerning symptom here.
I agree.
And the other thing would be if we encourage people that when we ask them to unmute, it's best that they unmute so that they can share their wisdom to us. And so we can learn, the learning could be both ways.
Yeah.
Right. I agree. But this is very good for starters.
I think so.
Yeah.
Well done.
And Ed, this is our second spine bowl, actually.
Okay. Was I on the first one?
Yes.
Okay.
I'll send the recording to you.
Getting old.
I'll send the recording to you.
Okay. Well, this one was definitely a success. So thank you, everybody.
Okay.
Have a great rest of day and go forth and prosper.
Have a good run, Ed.
Yeah, thanks.
We
Bye-bye.
thank all the organizers.
Bye-bye.
Thank you. Goodbye.
Bye-bye.
Bye-bye.